I see a lot of conflict between generations, like, oh, my parents don't understand or my kid doesn't understand. And that's always been a thing. Parents and children will always argue. But what I see specifically is, this real disconnect of, are you working hard enough? Or you're not working hard enough. So for instance, if our parents came here and they had to overperform, they had to be perfect because they had to. They already had all the cards stacked against them. So if they're struggling in that way, then that's what they're going to pass down to us.
Hello, and welcome back to the Governor's Institute Addiction Medicine podcast and our three-part series on Tarang. I'm your host, Pooja Mehta, creator of Tarang. In our first episode, we talked about substance use disorder in Asian American and Pacific Islander communities, including some of the stigma and cultural dynamics that can make these conversations difficult. Today, we're continuing that conversation by taking a closer look at barriers to care, what it can look like to seek support within the healthcare system, and some of the cultural and structural challenges that can impact access and treatment. I'm joined today by Dr. Ramirez and Dr. Riataza, two professionals who bring important clinical perspectives and experience working with AAPI populations. Dr. Ramirez, Dr. Riataza, I'd love to have you introduce yourselves. Dr. Ramirez, would you like to go first?
Sure. Thanks so much for having me in the podcast. My name is Noel Ramirez. My astrological sign is Cancer. I am the founder and director of Mango Tree Counseling and Consulting. We're an Asian American mental health group practice servicing Pennsylvania and New Jersey. And I am also a senior lecturer at Columbia University's Graduate School of Social Work.
Wonderful. Thank you so much for joining us today. Dr. Riataza?
Thank you so much, Pooja, for having us here. And it's so great to be able to work with you and Noel as well. So my name, Mariel Riataza, my pronouns are she, sha. And for those of you who don't know, sha is the gender neutral pronoun in my native language, Tagalog, and it's the only pronoun we have. And my astrological sun sign, since we're sharing it, is Aquarius. My background is in medicine, health policy, and education. And I am currently the executive director at the National Asian Pacific American Families Allied for Substance Awareness and Harm Reduction. And we're based in Los Angeles. Thanks for having us.
Thank you both so much. Dr. Riataza, you touched on this a little bit in your introduction, but your native language is Tagalog, so you're Filipino. I'm wondering if you could tell us a little bit about your cultural background and how is substance use and addiction treated in that culture?
Yeah, I think that's a really important question when it comes to anything behavioral health related. So my background is Filipino. I'm also Chinese. I was born in Philippines and I came to the US when I was 5. So English is my second language. Tagalog is my first. It's really hard, honestly. Not only do we face cultural barriers as far as, how we perceive mental health and substance use disorder and other kinds of addictions, but, it's as far as access, we're not just talking about costs. We're not just talking about, is there a provider in your area? We're talking about language. We're talking about, is the care that is provided culturally responsive? And when it comes to communities like mine, and many other AAPI communities, there seems to be a mismatch in how we talk about things, how we approach things. And that makes it really hard for people in my community to seek help. So, I'll stop there.
Thank you. Dr. Ramirez, what is your cultural background?
So many different ways to answer that question, but I would definitely, similar to Mariel, I am also Filipino American. I was born in the U.S., so I can really speak to the diaspora, right? And what I saw in my communities growing up. I grew up in Jersey City, which is an actual enclave, Filipino enclave in the East Coast. And so when it came to addiction and mental health, period, one of the observations I noticed is even the language was missing. And I thought what was profound about that as a young person, which really set the tone for me in my career, was that, without language, all we have is our bodies and our relationships to act out our pain. And I saw that a lot in my own family. I saw that a lot in the communities where there was a lot of addiction concerns that just didn't have a name. And even the language I would hear in Tagalog were not clinical language, it was often pejorative. Often, I would hear things, language associated with discipline and religious coded language that was surrounding what happened to a lot of the families that fell from addiction in my community. So at least in the diaspora, I can say, at least in the New Jersey diaspora, shout out to Jersey City, I certainly saw a lot of vagueness and just like a lot of nonverbal communication about something that was taking up a lot of space in some of the families that I was close to, including my own.
That really hits. That really hits. I think about that all the time. Obviously being part of my own communities, I grew up all over Southern California, but I spent a lot of time near Little Saigon in Orange County, and I grew up with a lot of uh, young folks who were children of refugees, either from Vietnam or the Khmer Rouge. Growing up, my best friend, her family survived the Khmer Rouge, and my other best friends, they survived the Vietnam War. And I think that those are things that are really, really difficult to talk about. And so, just really echoing back on what Noelle had said, that there are some things that you just can't put words to. And when we can't name them and we can't release them, then it manifests in our bodies and it manifests how we treat ourselves, other people, and just really recognizing the power of words. I appreciate you saying that, Noelle.
And one thing I'll just say is a very specific observation that I noticed, at least in my community. And so, Jersey City, many of the Filipino folks that I was around, my parents included, were factory workers, labor workers. Like, again, we can have a whole podcast about Asian America and labor as a sort of like through line, but the only time I would hear addiction or anything even remotely close to it was when it got in the way of earning. And and then it would always be like this barrage of like comments or chismis about like, oh, they don't have any money anymore, so much shame. But like we saw it, like we were
Yeah.
seeing it, but like it was only when like something got in the way of earning and like that sort of like honor associated with like trying to like send remittances or really when it became public. And so like I think that was one of my earliest introductions to a very particular flavor of shame that's associated with Asian American mental health and substance abuse.
I think that's so interesting because, my background, I'm Indian American, but that dynamic is also heavily reflected in Indian culture, right? Our immigration story as a, wide variety, or by and large, the Indian immigration story in America is quite different than the Filipino immigration story, but yet that dynamic of mental health and substance use not even being spoken about until it gets in the way of quote unquote success, right? Economic success, educational success, reputational success. It's really interesting. And, I wonder if, like, are those conversations happening behind closed doors before it becomes a barrier, or is that just when it's becoming a public conversation? But either way, right? Like, I get the sense that in the Asian American community, like, we're not talking about this problem until it starts affecting kind of other people, right? There's not that kind of intervention when it's harming the individual, right? And I wonder if that has something to do with like the heavily collectivist cultures that we come from. But, and there's that dynamic as well between Asian culture and American culture and all of the things. So, but that's a very fascinating observation. And so kind of to that end, we know that substance use and addiction is a very taboo topic in Asian cultures. And yet both of you are pursuing professions that directly work in that space. And we know that, the stigma and the judgment on the topic does not, like that translates over, even if you're working in that area in a professional space. So what made you want to get into substance use support? And how did your community respond to that?
I can go first. I actually didn't plan on going specifically into substance use disorder, but it was after I'd left medicine and I had finished my master's in health policy and law. And I really just wanted to change. I didn't really want to do anything really medicinal or medically hardcore because my background was surgery. And I wanted to try a profession that focused more on the cultural aspects of my identity because it's not really something that I'd experienced. And, coming out of medical training, you kind of lose yourself because the training is really, really difficult and rigorous. So, I tried and I really fell in love with it. And that was my first job, really. I started at the very bottom as a project associate at Napa Fossa. And I tried it out because at the time we were working on problem gambling. And I was like, well, that's really interesting. I've always known about gambling, but I didn't know about problem gambling. And I was like, yeah, I could probably name a number of people in my family who maybe gamble a little too much. And it just really opened my eyes to to how folks interact with clinical information on a different level, not just on like a physiological level, but really on an emotional community level. And it really showed me where so many gaps were in my own understanding. And it also, I would also say it saved my life. I probably, well, I identify as someone who is in recovery. I've never been diagnosed specifically with substance use disorder, but I can tell when I'm using something a little bit more than I should have. And, we all try things when we're young and kind of growing up. I understood that there was something wrong, but again, I couldn't ever talk about it. When you can't talk about it, it just gets worse. And here I was facing this, new pivot in this job for the first time and really not just humbling myself and humbling what I thought I knew about health and healthcare, but, really giving me a chance to reimagine what it could look like and what it should look like.
Dr. Ramirez, anything to add?
Yeah. So the question is, how did we find ourselves in this work? And I can share that, for me, it's all about like personal lived experiences. When I was in my early 20s, I was really knee deep into the circuit scene community. And for those who don't know, that's like a sort of club scene in particularly gay meccas in different, areas. And I really had a real problem with problematic stimulant use. It was part of the culture, and I noticed I was engaging in a lot of self-destructive behaviors. And one of the things that really saved me was accessing the recovery community through 12-step programming initially. And it was in that program where, one of the tools of recovery that really spoke to me and shaped me was the power of story. In these rooms in the recovery community, you get to bear witness to people's souls, people's stories, and people's roads to resilience. And I was moved, I was lucky to have a geographic intervention, and I was able to really start over in a different city and really create a professional identity that I, was shaped by that and many other experiences that was really rooted in creating access. That had been sort of the through line in all of my work. I first started working in HIV where not only substance use, but also process-based addictions like sex addiction and other problematic sexual behaviors were really introduced in and manifested really in the body. And then, after that experience, I really was craving more connection to the recovery community because at that point I had become more ingrained in the recovery community, the rooms, and really like doing service work in a lot of my home groups. And so I started working in methadone because in Philadelphia we have a huge opioid issue. And I worked in a methadone maintenance program as an IOP therapist. I also oversaw a Suboxone program through 5 different FQHCs. And so it was in that particular experience that I really saw the power really of access, particularly in providing integrated healthcare. In primary care, we were providing Suboxone, which at the time was pretty controversial and also something that was really new, right? Because people didn't have access to Suboxone unless you went to specialty care. And that was really where I really saw the power of access. And now even with Mango Tree, we have our own Smart Recovery group, Tuesdays at 8:30 p.m. Check it out. But in every sort of space that I occupy professionally. I make sure that there's language of recovery and resilience because it's super important, and it's something that a lot of people can really feel and see in their lives.
That's awesome. I love that. I think you both touched on in your answers, aspects of addiction that are not necessarily substance use, right? Marielle, you talked about how your introduction into the space and kind of what you were seeing in the community was in the problem gambling realm. And then, Noelle, you talked a little bit about how the your work really like touched on like sex addiction and physiological addictions as well. I'm wondering, are these, culturally more prevalent in the AAPI community than, your classic opioid addictions, prescription addictions, the way that we generally think about substance use disorder? Like, what are some of the things that we need to keep in mind as providers, as clinician, when we're serving the AAPI community with addiction and substance use disorder?
It's a good question, Pooja, and like it's a complicated question, right?
Yeah.
So, the first thing I would say is, and I think this really speaks to our larger community, is it's the issue of proximity, right? And so I don't know if the research that we have right now really well documents our experiences. And I say that because to your
Mm.
point, I had a similar thought around opioid use treatment in that like I had spent years working in methadone and different places where we were working with folks who were really struggling with opiate use disorder. I had never seen somebody who was who was visibly AA and HPI. Rarely saw that demographic in the care centers that I was working with until we integrated Suboxone at a federally qualified health center that was also in a community where there was proximity. And and it wasn't like this is a Suboxone program. No, this was primary care.
Mm-hmm. Mm-hmm.
This was where people were getting their primary care. And it just so happened that people, when they saw that there was recovery-oriented primary care services at this particular place, that people sought it out. And I was really surprised in that particular experience to see like our first clients or like some of the beginning folks coming through who were within our community. And that to me, like really spoke to who were, and, like the storylines are really, I'm combining multiple stories here, but like folks who had opiate use disorder for many years and didn't realize that Suboxone was an option,
Yeah.
Mm.
or even that insurance paid for that, you know what I mean? Or that, the accessibility piece here. So I don't know, like, again, in terms of population health stats, I'm skeptical around
Yeah.
like who has what, where, and how. But to your point, it is very, very common for folks who have some sort of substance use disorder to have a comorbid process-based behavioral disorder. And sometimes it's the same time, sometimes one builds on the other. Like I do a lot of work with folks struggling with chemsex, which is like the use of something like crystal methamphetamines or GHB paired with marathon sex in particular establishments, right? And so we see, it's very alcoholism, GA was created by folks who were recovering from alcoholism, right? And so there's a sort of tied piece to it. Certainly the broad strokes that I see in our practice are often lots of challenges with eating disorders. I think that's a very specific situation that comes up a lot with folks, especially with our backgrounds. I see a lot of problem gambling. I see a lot of financial disorders, particularly workaholism, as well as under-earning and debting. Debting is a big one. There's also lots of challenges with either sexual acting out behaviors or even sexual anorexia, and so I think I see a lot of those variances, you know what I mean, in our community. But yeah, and again, like I have this joke which kind of tells you a little bit about my family is like, it gets real when the mahjong table gets flipped over. Like these are all these like memories of,
Yeah.
oh, like most people who have a healthy relationship with gambling don't flip a mahjong table and like gun for people, right? Like I saw that
Yeah.
growing up, and that's kind of, and I joke and normalize it, but like that's out of control behavior. Like that's it's out of control. And so
Yeah.
again, naming it, claiming it, I think proximity, proximity, proximity. If we don't see ourselves, we don't go there. And
Sure.
so, I think that's kind of how I would respond to that.
Yeah, well, I definitely agree with everything that you said. And, I think that when we limit addiction to more strictly just substance use disorder, we're really missing out on a huge part of our community. And you're right, we have very little data. For as long as SAMHSA was reporting how AAPIs were accessing, behavioral health services, they don't track it anymore, or at least they're not reporting it. But we're number one at not seeking services every year. And when it comes to what do we typically see as the most prevalent substances? So I'll already agree with what Noel already said, but in addition to that, what we see here in LA, meth, so stimulant use tends to be higher. Opioid use is actually not that high as far as what we've seen. And, this is over years and years of data, but also just comparatively to other groups. And by groups, I mean like ethnic groups. The other thing that we've seen a lot is tobacco. We see a lot of vaping.
Hmm.
And then, you see those vapes that have like matcha flavor and, lychee flavor. And, there's a lot of pandering there. There's also a long history of, especially Filipinos and other communities, specifically the Black American community, have a lot of menthol use. But, those flavors, right, are what help get people addicted because it makes it more palatable, just like vaping. And then, what I'll also say is something that I know we see a lot in advocacy is that if we don't see specifically an addiction behavior, what ends up happening is we see it in suicide. And, I think that really just speaks to the power of what happens when you feel alone, when you feel like you can't reach out, when you feel like there's a lot of pressure. And, you know, year after year, our communities, our youth tend to have the number one preventable cause of death among our youth is suicide.
Yes.
And that's just something that we don't talk about. And I know, Pooja, you got a lot, you can say a lot to that. And I'll let you tell your own story. But, there's that. And I'll just answer one last piece about, how do we compare it to other communities? And this is just echoing what you'd already said, Noelle, is that when we don't show up, other communities also don't recognize us. And I will also say that they don't see us seeking help, but they also don't see us in these spaces often as providers. I used to be on SAMHSA had the steering committee for harm reduction, and I was the only person there out of almost 20 people who was of AAPI descent or who was there to speak on behalf of AAPIs. And everyone's like, "Oh, I didn't know that y'all had problems." Like, I know, it's because we don't talk. I know, that's why I'm here. But by the time we had finished all our work, we wrote our framework. They were saying, "Oh, you can't lump all of Asians." And that, like, do you know how many languages and cultures there are? And I was just so moved by how easy it was. I didn't have to really fight or defend for our communities. It's just like, oh, okay, we see you, we understand. And that really impacted me in a way where I saw where other communities were coming together in this space, but I just would look at ours like, what are we doing? Why aren't we moving forward? And I have a lot of thoughts on that, but I'll save that for later.
No, I mean, Marielle, you're absolutely right. Like, the Asian American community is incredibly, incredibly diverse, and it really is impossible for any one of us to be able to comprehensively speak to the experience of all of us. And also, very few of us are choosing to be in these rooms and have these conversations and kind of like name that these are things that are happening in our community that need to be addressed. So, With that being said, a big driver of that, is this culture of silence and shame around these topics. Addressing that culture of silence is what will both get people talking about the need in our community, but also get people being willing to be part of the solution for our community, right? Maybe getting more of us to be in these spaces, to be advocating for these changes, to be providing that care. I'm wondering, how do we do that? Right? What are your thoughts on how do we create this culture within the AAPI community beyond that's supportive to those of us who are struggling with addiction, struggling with substance use disorder, and then as providers from the community or who are choosing to serve the community, what are some things that we need to keep in mind as we're trying to create these spaces for people to get to a place of recovery?
Well, I'll take this one first. We'll take turns. I'll just echo back on something that Noelle hinted upon is that, you really have to lead with honey and not vinegar. Um, you can't just go up to someone and be like, "Hey, you want to talk about drugs?" It's not gonna happen, And it really comes down to the connection piece, right? Like this is something that is really hard to talk about. It's hard for you to bring up. It's hard for the person who wants to bring it up to you. And it's going to be uncomfortable. And I think we've grown into this culture where if something feels uncomfortable, and part of it is cultural, I'm sure, from our own ethnic backgrounds where, you're taught to not, the whole safe face culture, right? When we can't actually meet ourselves where we can't do it for each other. And
Yeah.
this is the really tough part is, for all the years that I've been doing advocacy, at the local and also at like the national level. Something that I really struggle with is even leaders in our own community to advocate for this. And it's like, look, if you want us to talk about stigma, you have to be willing to talk about stigma. You have to practice it. You can't just talk about it and then not really elaborate, And part of it, if you want people to really lean into that is you have to show them that it's safe.
Yeah.
And we're not seeing that in a lot of leadership. We're not seeing that in, obviously a lot of the news. And so I'm really asking everyone, for us to make this happen, yeah, we need access. Yeah, we need policy. Yeah, we need money, but we also need your heart because if you're not going to allow people to feel safe to talk about it and you're not going to allow people to even challenge what, good mental health hygiene and a support network looks like, then we're not going to get there. And I really think we really have to take a honest look at ourselves. What do we really want out of this? Or are we just going to wave our hands and keep doing the same thing? Because I'm tired of it.
Noelle?
I can, I'll answer this question as a clinician because that's my vantage point in that, I think we have a real structural issue, right now in the institutions of mental health in that AA and HPI providers represent about, I think it's less than 4% of the
Yeah.
current psychological workforce.
Yeah.
And
And
so,
it's very like hub based, right? Like, that's heavily, clustered in certain areas.
yeah, yeah. And I remember facing that very directly when I started an Asian American mental health group practice, right? Like who are we? Where are we? Like, what is this? And what I found in my work, especially having been, practicing clinical social worker for the past 16 years is that, it's bidirectional in that if we're not there, people don't go there, and vice versa. The canon of mental health, if we're not there, we can't contribute, right? As clinicians and as providers, right? And it's the people that are there that get to set the standard. And so with only 4% of the psychological workforce, and majority of the workforce being maybe non-people of color, we are dealing with an institution that's really rooted in white identity, right? And that's where we see a lot of the like near misses, right? And so to your point, I think the question that you had asked is, what are things to really consider? And I think, at least at Mango Tree, what has been a particularly tricky topic for us, and a topic that we embrace is, we made two promises to the community. One was to provide culturally responsive care, and the other one was to really cultivate a pipeline for AA and HPI clinical talent. And so we supervise our clinicians. We have about 24 Asian American therapists, and we have been really thinking a lot about what is best practice in our practice. And I think what we've created was, we have to understand, and this is where it gets missed in most mental health providers, best practices for generalist psychopathology, right? Like that's just, you learn that in school, you learn that in your continuing ed, you learn your best practices. But what's missing in clinical care is an awareness and understanding of the meta-narratives of the diaspora, because those meta-narratives complicate the psychopathology, right? Somebody who is coming here with a lot of indebtedness has guilt and valuation of self that might manifest in depression. So if we can deal with the depression and we don't deal with this sort of meta-narrative of indebtedness or generational trauma or, lots of enactments of war that have happened generationally, the caste system, colorism, colonialism, if we don't have a working knowledge of that content area, best practices fall flat. And so I think we're in an era right now where that's, well, one, it's being talked about, at least in social media, but I think institutions need to change in their training program, which is why I'm really grateful to work at Columbia, because there's a lot of this language and discourse baked into our curriculum, but our providers aren't being trained in that. That's the specific training that we have at Mango Tree, because one, our lived experience, and two, we're servicing clients. We have our group supervision. This is something that we're really co-constructing, but I don't think a lot of providers have that sort of framework. And that is often why my white therapist didn't get it. You know what I mean? Is because that meta narrative is important, and not just knowing it, but like truly seeing how it interacts with like the inner world of people. I don't think, the canon of mental health hasn't really, created language for that. And I think we're just in an interesting place to do that right now.
Yeah, if I could just add to that, there's a couple points that really just, I was sitting with what you said, Noelle. The first one I also think about is the fact, so I'll speak as an MD and, as a physician, I got very little instruction on behavioral health. I mean, I had, 6 weeks of my psychiatry rotation, but, that was back in, when did I graduate? 2014. And, as time has gone on, what we've seen actually is that psychiatrists don't actually do therapy anymore. And they just prescribe meds, and they're trained to, right? But this is a systemic issue. And this goes back to the structural pieces. So if when you go to see your psychiatrist, it's just a med check or, a med change, and you're actually not spending time with your psychiatrist as much as you are with your therapist, ideally you're getting both, then, there's a lack of continuity. And this is also a value thing in medicine, right? It's, if you're not spending time with it, I mean, how much nutrition education do we get? Very little. But, coming back to just how we're trained, it's not a priority, and it's becoming less and less of a priority to really get to know our patient populations. And part of it is just bureaucracy. I remember, just being in clinic, and it's like, well, if I get double booked and one of my patients is a teenager and I have 15 minutes and I have to ask them about depression. I mean, how do I build rapport like that? You just, that's a relationship. And, when you don't even have the capacity to do that. And, as time goes on, we're having a greater crisis in, lack of providers in all kinds of ways. The pressure is just building, after COVID, and I already stopped practicing by then. A lot of my friends had been burnt out. Yeah. So how can we even be there for our patients, our clients, right? When you're barely there for yourself.
No. I mean, you guys brought up some really, really incredible points. I think for me, the biggest thing that's really sticking with me is the relatability, right? I really want to like highlight how both of you got into this work because of your own direct lived experience. And I'm in this space initially as a patient, right? Like I'm not a clinician, I'm a peer advocate. And for me, the most powerful tool is my own story, right? Being able to share my own experience and have people kind of recognize, Mariel, what you said, that safety, right? That I am somebody who quote unquote gets it. But I think as clinicians, right, like you're almost prohibited from doing that, right? You're not supposed to make it about you. You're supposed to like keep the focus on the patient. But if, you know, like for me, the power in being able to speak to someone, it doesn't come from the degrees or the schools or the letters behind your name. It comes from your ability to see somebody else's experience in a way that they know is not going to be met with that judgment, that stigma, that shame that they're so used to receiving around this kind of thing, right? And it really doesn't matter the accolades that come with you, if you're not able to do that.
Can I just add one more thing to what you said?
Sure.
So I just want to highlight something very important that you had mentioned is this: there is clinical behavioral health, and there is also community behavioral health. And you do not have to be a clinician to care for your neighbor, to care for your friend, to care for someone that you don't know. Maybe you see them crossing the street and they just need a little bit help. And I really want to emphasize how important this is, because this is when we make connections. This is when you get surprised by the people you know and you're like, oh my gosh, you like that too? I just found out that my orthopedic surgeon is going to EDC this week. And I was like, okay, cool guy. So, I think there's really so much power and connection. And that is something that we have lost in these years of just division, social media bots dividing us. I don't know, Cambridge Analytica, everything going on. We have to find our way back to each other, because without it, I don't know where we'll be. I don't know. And that's the scary part.
Well, I mean, that's a beautiful transition into my last question. Asian American Pacific Islanders community is so important to us, right? The way that we work, the way that we live, the way that we think. How do we create that culture within the community that can really allow for these conversations? And kind of in the same vein, what does the future of recovery for the AA and HPI community look like for you?
Can I just say that when we mean recovery, it can look like abstinence and it can look like another way. And, we didn't really get to talk about this earlier when I was talking about Suboxone, but Suboxone is what we call, medicine assisted treatment. And it's another type of, opioid analog. And I think something that we have to really acknowledge is that recovery looks or can look like a lot of different things. But the point is, are you getting better? Do you feel like you have things in control? A lot of these addictions are control based. Like you're seeking control, or you've lost control, or you're escaping something. It is a coping mechanism. So if we per se, right, if I'm, addicted to, I don't know, heroin, what am I escaping from? And if that never goes away, then it doesn't matter how many times I go to rehab, right? I'm going to end up back where I am if I can't make those lifestyle changes. And these lifestyle changes are really big for everyone. And so it is a community call for everyone to be kinder and to be more responsive. And this is something that we have to practice over and over and over again. Remember, building relationships takes time. You see each other repeatedly, and sometimes you fight, and then sometimes you get back together. But I think what we've learned from these years of social media and how many characters you can get to, piss someone off is things aren't really permanent like they are on the internet. Mm-hmm. When you have a conversation with someone in person, things are imperfect. Yeah, you're going to say things you can't edit as, like you're editing your typing. But I think that there's a certain grace that we have to give ourselves and each other, that you're going to say some of the wrong things. Just count on it. It's going to happen, but you have to keep trying. You have to. We must.
Noelle?
I to answer both questions, there's this really beautiful saying in the recovery community. There's so many different recovery communities, but I'm citing 12-step. Again, shout out to Dharma Recovery, shout out to Smart Recovery, shout out to LifeRing. There are plenty of different traditions, but the ones that I'm most familiar with is the 12-step tradition, and they say that the opposite of addiction is not sobriety, it's connection.
Yeah.
And I think a lot about, even just in my own experiences when I was really active, in my addiction and with some of my compulsions, and how isolating it is. And so the real cure in at least a peer focused recovery community is the power of connection. And I think, if I can even just say like the power of connection, in that I hope that we can, the future of, I think, our work is building up this pipeline to be more than just 4%, to really transform the mental health landscape. I think, again, another sort of continuum of work when I think about the recovery framework. And what I mean recovery in this concept, I'm not just talking about chemical recovery, but even the recovery of like trauma, and the trauma of acculturation, the trauma of immigration, the trauma that continues to live in people's bones. At least in mental health, we talk about like, at one end we have trauma, and on the other hand we have integration. And I think we're just moving towards a state with integration where we're starting to build a common language around diaspora in our community. I think across AA and HPI communities, as a diasporic community, I think we're beginning to create a shared language. And I think when we start to cultivate that language through mental health providers, peer advocates, advocacy folks, when we come together and create this language of connection, I think we'll be better integrated in ourselves. And that's what I really think is the spirit of recovery, right? Is that all parts of ourselves can exist, and that we're not in these like compartmentalized spaces. And I think with many of us in the community, especially in the diaspora, we do live very compartmentalized lives. Much of our mental health journey is about integration and seeing like connection within our whole. And so, that's kind of my vision and hope for the recovery community and the AA and HPI community. Again, shout out to our Smart Recovery on Tuesday nights. But if folks do look, there are affinity groups in recovery spaces that exist, right? And so I think that I'm starting to see that more and more. I didn't see that 16 years ago. I didn't see that 20 years ago. But I'm seeing a sort of pulse of wanting connection and affinity. And I think we're working on it.
Dr. Ramirez, Dr. Rayataza, Noelle, Marielle, thank you both so much for joining us today and for the wonderful, wonderful conversation. And thank you for listening to the Governor's Institute's Addiction Medicine podcast and our ongoing Tarang series. Stay tuned for our next and final episode, where we will continue the conversation with folks from the community sharing lived experience perspectives. To learn more about Tarang and other initiatives focused on substance use prevention, treatment, and recovery, visit the Governor's Institute website at governorsinstitute.org. Thank you so much.